Welcome to the Chief Healthcare Officer, the podcast for healthcare leaders shaping what comes next. I'm your host, Dr. Fatih Mehmet Gül. In my book, Connected Care, I argue that the future of healthcare isn't just about deploying better technology. It is about technology that genuinely serves people. That the role of technology in healthcare is fundamentally to provide empathy. Today's guest lives that argument every day. Nancy Wright is VP of the Commercial Services and Digital Platforms at GE Healthcare, where she advises health system administrators and C-suite leaders across the United States on complex system architecture, digital transformation, IT infrastructure, cybersecurity, and whole health system solutions. She has led enterprise transformations worth over $800 million in transaction size. And she's here today with me, not just to talk about what GE does, but to get into real questions facing healthcare leaders right now. And I should also mention, this is not a sponsored episode. I have been following Nancy's work for some time and simply wanted to have her voice on this show. Nancy, welcome to the show.
Thank you so much. It's fantastic to be here with you today. I echo that. I follow your work as well. And I think these conversations are so rich. So I'm looking forward to having a nice coffee chat with you.
Thank you so much. I really appreciate it. I was able to give you a very quick introduction about yourself, but if you want to add something, please feel free. I'm sure the listeners will be very happy to hear your own introduction.
Absolutely. So my journey with GE Healthcare, but I think mostly just in healthcare, stems from a passion of closing the gaps, right? So I come from a bit of a different background. One of the biggest questions that I get is, are you clinical or are you operational? I have a saying that I grew up outside of GE, but then very much learned healthcare along the journey. So I came in from an operations perspective and then quickly saw some of the gaps in commercial, right? In terms of when I look at commercial and what is commercial to health systems and what does that mean? It's not about, and it should not be about selling. It should not be about moving equipment. It should not be about moving technology. When I look at commercial and what our people do to help health systems and help clinicians, it should be about making sure that clinicians have the right tools and the right resources at the right time. So I quickly moved from what was operations and my background prior to joining GE, learned as quickly as I could about the health systems. And it really just became about making sure that we could serve and that we could complement the needs of clinicians. So that's really what I do, outside of all of the other great things. But that is what my heart and soul is about.
Thank you so much for this introduction. And I'm glad to hear that in the commercial world, there are someone who is coming from the operations, which makes our understanding easier as the healthcare professionals.
Absolutely.
Thank you so much. In my book, Nancy, I open the chapter 6 by describing three problems that technology must solve for healthcare: amplifying the empathy, extending human capacity, and streamlining care delivery. When you look across the health systems you work with, which of these three gaps is most underaddressed right now?
I'd say that the cross section of what you talk about in your book and where we are in terms of having that linchpin apex very much comes from human capacity. And it's a problem that has been, we know about it, we've talked about it, we talk specifically a lot about labor shortages, but what does it mean in terms of how it adds more and more complexity to healthcare and delivering healthcare? So when I talk about operations or when I talk about making sure that our physicians are well equipped with what they need, um, the biggest transition right now, or what we're seeing that continues to have the slide back effect, is actually in human resources and be able to fill that. So we're approaching healthcare right now, and a lot of the complexity around delivery models and optimization and all those great buzzwords that we're hearing. But the biggest part that I see criticality across every health system globally in the US, really comes from workforce shortages and what we're doing about it.
I hear you. I think it is not just the US. I mean, when we look at the global healthcare market, even in this part of the world, we're feeling this every single day. I mean, the new coming professionals are not enough for the demand what we have. And I totally agree with you. Now, if I go to the next point, I mean, you have spent over a decade at the GE Healthcare, working directly with health systems on transformation. What drew you to this intersection of technology and clinical operations rather than a more traditional clinical and commercial path?
Yeah. For me, I call it solving the gray, right? So in the approach that I have now, I look at, how I grew up and how I call it in operations, problem solving, looking at a lean background, things like that. And a great mentor of mine actually challenged me to say this is very transferable into the healthcare space. And I didn't really understand that until I spent time on site, until I spent time in emergency rooms just watching the flow, until I spent time understanding the capacity flow of ORs, of radiology departments, and how all of that interconnectedness was actually broken. And it's not because it's not because clinicians and clinical leaders are not actually doing the right work. It's because the infrastructure all around them is actually broken. It is excessively siloed. It's excessively behind. So when we talk about transformation and what brings us to where we are today, that journey is going to be a very long one. But for me, that's where I had that aha moment, that passion, that fuel to say we have to close the gray area. We have to close the gap of what clinicians are doing and how they're able to accelerate, and then that trickle down effect of how it goes on to patients, and then people that are trying to do the right things but necessarily may not be able to because we have created systematic silos.
I totally agree. I mean, and I love to hear also from you that you're talking about the things on the ground. And then, as a hospital CEO, I love having my rounds. And this is the only way that we can understand actually how things work. And I like the point about the infrastructure, what you say. But just to, I mean, correct some understandings. GE Healthcare is one of the most recognized names in medical technology globally. But I think many healthcare professionals still see you guys as primarily as an equipment company. How would you describe what GE Healthcare's medical technology advanced services team actually does in plain language?
Absolutely. So we're extremely proud of our legacy as being a medical technology company. But I look at it as the necessity of people, process, and resources, right? So if you only have technology on its own, you can have the best technology in the world, but if you're not harnessing the capacity and workflows and optimizing that technology, you basically have very expensive shelfware. And it goes for the other way around it as well, from a people perspective and a human centric perspective, in terms of making sure that humans are actually enabled by the technology and excited by it as well. So that three-legged stool, that's very much required for us to be able to have systems that are, yes, delighting, but then also doing the work and then re-delivering on full ROI for a health system and for clinicians, is really where medical technology advanced services was born. So in 2023, 2024, I took on the journey with GE Healthcare to say we need to help our health systems better have that transition in the market where it's not such a cold start. Yes, we're delivering equipment. Yes, we're delivering great technology. Yes, we're doing all these things. And then when we go back and we look at the journey of how they're progressing through the life cycle, adoption isn't necessarily as great as it could be. Or sometimes it's underutilized in features and capacity, which means that we're not serving our health systems the way that we could just because we don't know that it's there. So I very much look at medical technology advanced services, or MTAS, as the bow that wraps around, and then we work more upstream. We sit with the health systems, we sit with clinicians, we sit with operations, we sit with porters, we sit with every part of that organization that creates that patient journey or that impacts with that patient journey along the way, whether directly or behind the scenes invisible. And we make sure that as, yes, new technology is coming in, we're architecting for the life cycle of that technology. We're putting the human center back into it, into saying, yeah, how are you going to interact it? How are you going to make sure you're using it to the best of its capacity? And then we want to measure that along the way. So we very much positioned MTAS at the downstream or upstream impact, I should say, to be able to pre-design that with clinicians and health leaders so that we have a better downstream of the equipment utilization and ultimately the physician experience.
I have to really congratulate the GE Healthcare by hiring an operation person who speaks exact our language. Because whatever you say, it is something that on a daily basis we're dealing with. And thanks for this explanation. And thanks for your support actually for us to understand such things better.
Absolutely. It's something where if we're able to sit with you in those design, right? We talk about procurement, we talk about how do we select, we talk about all of those, what makes that the great hospitals of the future that we're building. And from an MTAS perspective, I'll use the acronym because if you know GE, we like our acronyms, but medical technology advanced services, we don't start with, let's say, a sell sheet. We don't start with a spec sheet. We start with a conversation. We start with what do
Amazing.
you need your departments to do? Where do you need your systems to go?
Excellent, excellent. And thank you for that. And I'm sure with this approach, you will have so many breakthroughs. So now back to the discussion. In my book, Connected Care, I write about the curse of intelligence, where smart people jump to the solutions, before truly understanding the problem. In healthcare technology procurement, this happens all the time, I'm afraid. Do you see that in the health systems you work with?
We do, and I look at it as a fortunate but unfortunate at the same time, right? I very much look at transformation and working with health systems and bringing back that human centric culture of it, and understanding that there is excitement, right? If you're going to design for something, or you're going to say we're going to open up a new facility, or we need to be able to transform a community, and we need to be able to adapt to what that community needs. And it's interesting how many of those exciting conversations actually start with there's a new tech on the market, let's get it. So or you walk into a conversation where it's supposed to be maybe the beginning or the board or kicking off a chart or something like that, and then we find out that they've already chosen a technology. They have already said, well, based on I went to this trade show, or I saw this event, or I have this great relationship. Now these are all great things to anchor on, or we're not saying that we shouldn't have those things, but if we were to just pause and kind of redirect a little bit, and if we had set up a system where we had an unbiased, let's say, evaluation, or we had a committee cross section to actually look and future cast and start from what do we need and what do we want to become? What do we want to be? What does our community need us to be or to serve in the next 10 years? And answer that and then structure blueprint that first, then you could reverse from there. So it's interesting how often we have great EMR system rollouts or great technology infrastructure or great cyber programs that roll out. And then unfortunately, when we go back and then we're all sitting as a financial committee, because then, we shift from excitement of let's plan the future into answering for financials as well. We have a lot of expensive shelfware. That is a very true statement for today.
Unfortunately, and thanks for mentioning that. And Nancy, Scott Becker is a very close friend of mine, and then I had the chance to actually watch and listen your speech over there in the panel. And one of the topics you proposed is that digital strategy requires disruption, that tweaking processes is not enough. So that's a strong claim. So then, very conservative, industry that we have, what do you mean by that? And where you have seen the cost of not disrupting?
Yeah. Healthcare by nature is very conservative, as it should be. There are things that as clinicians, as delivering patient care, as being physicians, it should not be disrupted. It should be very conservative. It's very much still the person to the person and understanding that. But when we talk about disruption from an industry perspective and why I encourage health leaders to really start to look at that and to come away from the conservatism, is the reality is that healthcare as an infrastructure, as everything that lives and breathes in your ecosystem, we need to start thinking about it that way. And if we don't think about our health systems as living, breathing ecosystems, we won't get into the mindset of understanding why we're 20 plus years behind. That is a true statement. So when I say, and it's one of those things where it does get a lot of eyebrow raises, as I call in a conversation. But I really do encourage health systems to try to harness both, to have that dexterity to say, yes, we want to be conservative in our care approach. We want it to be people centric, person for person. But you now have on the other hand where you need to have a living, breathing ecosystem. And if you're not, and if we're looking at supply chain, if we're looking at cybersecurity, if we're looking at all those other parameters in terms of why other industries that we can learn from have been able to accelerate their transformation, have been able to come out of the biggest pressure we're talking about is labor shortages, right? So every industry is faced with labor shortages and what they're able to do about it. So the question then becomes, why is healthcare lagging so far behind in operations, systems, processes to be able to catch up to that? So when we say we need to have a significant amount of that transformational mind, it's not about the healthcare delivery. It's about your ecosystem delivery.
I totally agree. In I think two previous, episodes, we had a guest, Mohan, from Silicon Valley, and then he was just mentioning something which I like very much. He was telling me that, look, clinically we have so many breakthroughs. But then the problem of the healthcare is the non-clinical ecosystem part that we need to improve. And without improving this, unfortunately, we cannot get the best out of our healthcare professionals. And we need to sort this area in order to support the breakthroughs of clinical work, which I really loved what he says. And I believe this is a global healthcare issue that we have to look at today.
I love that. It's like it's having incredible development in research at the R&D space, right? So it's now we're pretty much going to touch a little bit on the skills of commercialization, but you could almost look at it the same way. If your researchers and your doctors and physicians are doing great things in research and development, but then you can't get it off the ground because your infrastructure, your ecosystem is broken, then it's unfortunate. It will just sit there and it will never see the
I
light.
totally
So I
like that.
love the points that your colleague made on that podcast episode as well.
Thank you. Um, all what I have done for years, I have spent a lot of money on the technology and then digital transformations in my hospitals. And what I have seen, Nancy, if we don't put the care and human in the center of all these digital transformations, unfortunately, sometimes we're even creating the barriers. So, because of this, I created the checklist and also shared this in the book, in the website, everywhere for evaluating the technology through a human centered lens. So I created some questions over there, like, does it enhance face to face interactions? Has it been co designed with the clinical users? Does it reduce the administrative burden on frontline staff? When you're sitting across for a health system C suite, I want to ask you, how often are they asking these questions? And how often are they just buying the technology that the market is pushing them?
Yeah. I think when it's done in a vacuum, you see more often health systems that are actually doing the latter, that they're buying just what's on what the market is currently pushing, or they're going for that latest kind of innovation that just came in and said, well, we want this because this is how we're going to lead our digital transformation. It's the new tech on the market. We got to get it. Um, I believe that health systems that we're actually seeing mature and have the depth within their transformations are the ones that are sitting in those cross sections of evaluations, that are taking that step back and that are saying, hang on a second, we need to actually change the way that we are looking at our ecosystem or building out our digital transformation, because what was the speed of acceleration 5 years ago, 3 years ago is very different now. So I see health systems led by C-suites from a mature perspective that have actively and just with thought taken that step back and said, yes, we have a mass amount of technology, but if we keep continuing to just do the bolt on to the bolt on to the bolt on, what are we actually creating? What are we actually solving for? Are we actually improving, or are we actually going to continue to create more issues or have that beautiful R&D that doesn't see the sun? So I look at this for maybe, and I mentioned a little bit on financials, but if I'm very strong on operations and human centric care and bringing it through to what actually happens on the floor with clinicians, but serving all in all the longevity of a health system, and then considering the CFO, right? Considering this is the party organization that has to have a little bit of that criticality to be able to say, yes, we need to fund for today, but we got to keep the lights on 10 years from now. We want to ensure that we have our vision forward. We want to ensure that we're here for communities today, doing the right decisions, but we're going to double down and make sure that that is sustainable as well. So I look at that problem of the CFO and that part of the organization and partnering and teaming, and we can clearly see organizations that are pacing forward and creating that depth of transformation. I call it topical transformation or depth of transformation. And it's interesting because when you look at organizations that are doing that and that creating the depth of it and doing those right decisions financially and kind of pacing forward before advancing, you could see very, very clearly the organizations that are actually just doing a topographic, that are still doing bolt on, that are still chasing this latest and greatest and still kind of spinning their wheels. And it's interesting too, because when you flip the conversation over and you revisit them, 6 months or how is it going, all with very, very good intent. Everybody has the best of intent. But then when you revisit them and you say, how is this incredible adoption going? What is your metric? What's your goalpost? You can actually see the ones where they don't have a very strong percentage of adoption, right? So
unfortunately.
very interesting.
And it is not just in the one part of the world. It is everywhere globally in healthcare systems. But we should not, also forget one point. The digital transformation and then digital ecosystem development is, something we all have to work on it. It is inevitable. You cannot stop such things. It will happen. And then the question here, you have worked on health system transformations worth over millions of dollars. What is the single biggest lesson from those projects that you wish more healthcare leaders understood before they start a major digital initiative?
Yeah. This is something that on the journey we will continue to learn, and I think we will continue to refine. But just myself and self-reflecting where we've come, and in the last few years as well, because technology is now at the apex of being able to do something fantastic. That it is now able to actually reduce the time of what we call the barrier to care from a distance perspective, and then also just from having a time perspective. So I'll touch on that in a minute, but what I wish health systems would do more of from a learning is to actually that checklist, and whether it's your checklist, which is phenomenal, which actually when I was going through, I was like, this is exactly what we talk about. But I do wish that they would take a pause and do your community scoping first. I'm very, very big on that. Where we've seen it, and then where we've seen the success come from, and where we've seen some of the best transformations. And transformation is a journey. It's not a project timeline. So going on a digital transformation to say, well, this is a 12-month project. I'm so sorry, it is not. Transformation, if you decide to take it on within your organization, is going to be something that you're going to harness probably for the rest of your career. It needs to become anchored in your culture. It needs to become anchored in just how you work and how you present, and then how you lead your people. But I wish that before starting that, health systems would sit and they would say, what is that 10-year out need to be? Do we understand where our population is going? Do we understand where our dynamics are? Do we understand where our own footprint is, right? Are we actually able to look at landmass and what's going on? And are we able to actually do more? Are we able to serve more of the patient population because we can shift differently? And then having a better understanding with all of your clinical leads to say, we're going to need a lot more cardiology. We're going to need less mother baby. I wish that health systems would actually have those topographic conversations planning first before jumping into digital transformation. And I'm going to change my EMR over, and so by doing that, you're going to understand what you're designing to. So the art of design, the art of doing those sessions, is actually understanding what your end state is. And with the
Right.
technology now, as I talked about that apex, technology is finally breaking to the point where you could actually have with enough confidence, right? We know as we get further away in timeline, your confidence kind of goes down, but you should be able to cast out for 10 years and have a very good understanding of what you're building towards.
Very true, very true. I teach in UCL in London, and then we have so many great leaders coming to our courses. And each time when we start the conversation about digital transformation, we just want to discuss exactly the same issue. We don't want to discuss the digital solutions or the technology things. It keeps changing every day, but we just want to discuss what is our community's needs today and what exactly they're looking for and what lifestyle changes they have had and what is their expectation. Then we need to start building up the plans and everything accordingly. Otherwise, just the companies come and then we just believe the hype, and all of a sudden we just make this kind of investments. Then later, as you say, we wake up, but it will be too late. The whole investment will be there, underutilized. So much investment is made, then unfortunately we will not get any benefit out of that. I totally agree with you. So
I think one of
before
the
we
great things from just one of the great things from your classes and your seminars, though, is the idea that you leave me with of um, transformation for sake of technology is great, but we need to become shepherds. So as you're now
exactly.
going on digital, that is something that I very much got from a lot of your reading as well, and what kind of came to mind. So for healthcare executives and saying, well, it's I love that. It's not about picking your technology and what's the top of the, what's coming out to market in the next few years, but if you're able to shepherd your organization, and you have to be able to cast that forward and understand that community and then bring it back. So that's the word,
Totally
I
agree.
think, in terms of anchoring for me back to health leaders and administrators to say, are you shepherding your organization in a transformation?
Thank you.
Um,
Thank you so much. And
Absolutely.
I hope this will be amplified everywhere, and then we will keep talking about it more and more. Just before jumping to the strategy part,
Mm.
I have another elephant actually sitting in the room, which is cybersecurity. And I know that you have an amazing experience and expertise in IT infrastructure, architecture, and then cybersecurity. So, how should a healthcare professional, healthcare leader be thinking about cybersecurity as a strategic priority, not just technical IT subject?
Yeah. So cybersecurity creates oftentimes a great divide within health systems and for the right reasons, right? So cybersecurity, if you're looking at it as a cost plus your organization and something that is now just has to be added to the balance sheet, unfortunately, you're actually adding to that divide. Um, a bit of a background on it is from an industry perspective. So, industry to industry, we talked a little bit about how far behind now healthcare has just become in terms of that ecosystem in creating that environment that is nimble and adaptable because we haven't invested in it and we haven't actually grown it in that perspective. We've remained very conservative around healthcare. Patient delivery, absolutely, we should, but then the ecosystem, we should have accelerated a lot faster. So what that's created now in the globe and around the market, unfortunately, for bad actors or those people that are actually creating cyber attacks, is that they look at healthcare as a very, very ripe and easy environment to get into, and they're not wrong. So when you're looking across most health infrastructures that are 20 plus years old in legacy and then still trying to pace and go forward, um, my biggest thing with health leaders is that you can no longer look at cybersecurity as another cost on your balance sheet. We need to start looking at cybersecurity and the real impacts of it now because we've had enough ample data to be able to evaluate it as an actual patient safety event. Anytime you have something that is happening in a cyber perspective, and we've seen unfortunate too many incidents of it already, but it is a hard shutdown on your entire system. Like it is a we talk about walking the halls all the time, and I have a few examples where we're actually on site, we're doing transformational work, and there's a cyber breach that actually goes live while we're there. To experience that and stand in a health system that has now just had a massive shutdown within seconds, everything has to stop. You have ORs that are no longer feeding data. You have oncology systems that can't be seen. You have ERs that just completely drop off. And the reverse scatter that happens for every clinician, delivery person, support person now all goes back to pen and paper, and they're trying to just have delivery for their patient. So it's no longer the matter of looking at cybersecurity as this is a balance sheet issue. We have to figure out how to work it into budget. Cybersecurity needs to become a health patient incident for us to actually rethink on it and then engineer it into our everyday process.
Well, I know. I mean, there are so many incidents happening, and unfortunately, we became the target of those hackers nowadays because we are not like the bankers. I think we did not invest enough earlier. Bankers, they're doing an amazing job. I have not heard hacked bank for very long years, but now it's the healthcare, I guess, and that is something we need to keep discussing about it. Not just about the investment, but we need to make our people aware of such risk, I guess.
Yeah. So I guess and then what could we do? And it is a very big, could or should. But just let's start thinking about cybersecurity and embedding it into everything that we actually bring in. It's no longer a matter of having cybersecurity as a bolt on or let's do all of this. We have to continue, right? We have to continue to have the system technology turnover and infrastructure done and things like that. But make it a core part of your feature. Make it a core part of your assessment. Make it a requirement. It's no longer an optional for us to say, how are you securing your network? What is the systems or the technology that's coming in as part of your evaluation? How is that technology secured? What are you doing about it, vendor, to make sure that what we're bringing into our environment, our ecosystem can easily catch, right? It's not about there's risk on the device and then there's risk in the network. So they both have to play symbiotically.
100%. 100%. Now, I just want to jump to the predictive maintenance and then some strategy about the management of these equipment and then their strategy. So, in my book, I mean, I use the example of the robotic surgery at Kingston Health Science Center, where the technology saves nearly 500,000 annually in reduced IC admissions and readmissions at the same time. But then, what the patient experiences is simply getting back to their life in 10 days after the surgery, and then they can go to the pickleball court. So the best technology is always the invisible technology. That's what we have learned in our operations. Predictive maintenance feels like the ultimate expression of that idea, I believe. The patient never sees it, but when the equipment fails during a procedure, they feel the consequences immediately. So, how do you make that case to a CFO and then we can convince them and then go through this kind of strategy?
Yeah, I think for again, I look at the CFOs or the financials of it in terms of evaluating the now and the far and keeping us sustainable. So it is always a welcome conversation. But when we're looking at predictive services and we talk about how far technology has come, it almost behooves us that if we're not leveraging it and leveraging the power of predictability of failures that is out there and pressuring and pushing vendors more and more to be able to say, you need to optimize this technology because I'm going to rely on it. So I think the actual cost of just the actual, let's say, maintenance agreement or things like that, that is one thing. But what we do to help along that journey and is to be able to say, what does it look like across your fleet? Do you need the same criticality for all equipment? No, absolutely not. Let's get into that. But when you look at the reverse of it, I don't just look at I love your point on what is invisible because it's not just the fact of the cost of the actual system to the down event. We actually compute across the entire ecosystem now because everything is so interconnected. So when we look at the cost of an actual down system and how much it actually runs on that balance sheet, it's about how many cases you're not able to see. It's about how many patients have to be rebooked. It's about how many loss of technologists do you have, those hours, right? It's about loss of your radiology department hours. It's about your porters no longer having that workflow. So you could actually look across 20 plus data metrics to now calculate, is it worth having this predictive maintenance agreement? Yes, for the patient, ultimately, absolutely. And then where can we make some trade-offs? Do we have redundancy? Let's say we have ultrasound and let's say we have 12 ultrasound rooms. Do we have some redundancy? Maybe we can design for that. But when we're looking at criticality of mass in ORs, in emergency rooms, and things like that, we absolutely should be making the most of that technology for predictive maintenances. And then for anybody that's looking to build up those business cases, I would say look beyond just the actual number of the agreement or just the actual physical downtime and look for those 20 additional data points because you'll be able to find them pretty systematically.
It saved my life many times. I mean, having the right predictive maintenance agreement in place. But then I have to ask you one other thing. I mean, this is also something always in my mind. Always our supply chain teams bring the proposal in front of us, and then as the CEO, I have to agree or renegotiate and then move through. But then the question here, most of the health system conversations about the predictive maintenance focus on the large imaging systems, MRI, CT, because we always scare off any kind of breakdown. But
Yeah.
your work spans for the full equipment ecosystem. Where else do you think, I mean, health systems are leaving the value on the table through the reactive maintenance?
Absolutely. I look at some of the work that I'm most passionate about actually comes from our advanced asset management. And that has to do with anything but those nice, big, beautiful systems, right? So those systems, I say, okay, so, we've coined them, we've talked about them, it's great. But where so much of the value comes in unlocking and understanding the nuances and complexity of the value chain of equipment. I look at the value chain as something that is very, very interwoven. And I look at aspects such as ICUs. Your or we can look at into ORs. So when we work across different departments like that, and we look at the average patient now has about 12 devices that they're connected to. And if those devices, what happens most of the time is that when we're not casting proper maintenance on those devices, or we're not looking at predictability in terms of what they will need from an average failure rate, what happens is that health systems just naturally buy way too much. So that formula of having ventilators, of having pumps, of having monitors, of having these are all critical aspects to that patients need very much into ORs. It's not an option to say we cannot have the surgery go forward because I have an anesthesia machine down or I have a monitor missing. So what happens is because we're not doing the right predictive work ahead of time and planning out casting forward, we're buying way too much equipment. And that is so that is the work that I've become very passionate about because that is more of what is unseen. Those are those things that we can discover along that journey that becomes almost invisible. I'll leave you with a great example. We were working with a health system on their pump program. So something just, let's just take pumps as an example. 3 campuses, and they're saying, well, do I invest in replacing all of them, or my nurses are telling me, my charge techs are telling me, everybody's telling me we just don't have enough. What's going on? When we did the assessment and saw that they should actually be reducing their pump volume assets by 30%, which was a complete opposite of what every clinician was saying in terms of saying, I'm always running on the floor trying to find pumps, what's going on. So I leave that as a very, very real use case in terms of the work that can be done around all of the assets across that chain, and looking to uncover those pieces, those 12 devices that are pretty much always needed now in any patient that is in an inpatient capacity.
Excellent. I mean, I love having this kind of vendor and hospital conversation because otherwise it's all about sales, sales, and then different kind of commercial discussions. Then no one gets the value out of it. And I really appreciate for this approach. Pump infusion pumps are, I mean, a big issue. And then in my couple hospitals, I had great nursing leaders. Actually, they were doing a wonderful job on it. But definitely biomed is also important. And I don't want my biomed leader to get upset to me. But I have a question here. Looking ahead, AI is now embedded in the predictive maintenance platforms. How far does this go? Are we moving toward a future where health systems have AI partners managing their equipment, the entire equipment ecosystem autonomously?
I think it's a matter of both, right? So if I look at AI and technology coming and our biomed partners and our operating partners within hospitals, we actually look to use the technology and AI as an amplifier, and we very much need to, right? So if we look at the labor shortages and we fuse those two together, we work with health system now to be able to say, look. For our clinicians or our biomedical technologists, I love let's kind of stay on that track, that are now coming out of school, or the maturing of what their first 5 years of career looks like, or 5 to 10 as they go through those gates. We will not have enough resources to be able to replace what the health system pressures impacts are going to be. It doesn't exist. So we will always have equipment. We will always have a need for biomedical technologists. But the AI and what's coming into the market now to be able to actually tell us and do a lot more of that predictive, but now go into prescriptive, we need to allow the technology to do the work that it does so that we can catch up on our capacity. So we can have people actually doing the critical work and then still make sure that those systems are actually maintained properly or optimized. We have such a large gap right now in actually being able to harness optimizing of an asset fleet so that it's there for the care team. That it's no longer a matter of saying, well, I'm worried about AI that's coming because it's going to replace what I need to do from a predictive or prescriptive perspective. So those are conversations that are so well timed and that we're having right now across pretty much every organization, is to say we need this technology to come in. You need it to actually bridge your gaps, because we're at that point now where you're actually going so far below and we're so far behind in our work that we are going to create patient safety incidents. It is going to happen where a nurse is going to have to grab a monitor or a pump or an infusion device, and they're going to have to put it on a patient, and it will not be what that device needs to be safely. So those are you've touched on such a great point of conversation where they are now, but they will very much be future proofed. And I think the prescriptive of what AI needs to do to be able to prioritize the life of a biomed. They walk on site, they're responsible for 1,200 assets, and they have tickets that are read all day long. It would be a euphoric state for biomeds to have all of that clarity to say task one, task two, task three, based on the full ecosystem of what's going on, not just what they see in their lens.
And I believe in so many health systems, it is more than 1,200 because the shortage in the talent, we don't have so many biomed people, and we keep asking them run here, there. And in fact, if you have some of the aged also equipment, this becomes more, I mean, bigger hustle. Then they're really trying to, I mean, catch the pace, but it's not an easy job. And I totally agree with you. We need to prioritize all these things. Now, I just want to gear to the other subject. It is about the rural and the ambulatory care and then the others. I mean, I always try to share and extensively write about the technology, extending human capacity beyond the hospital walls, remote patient monitoring especially. telemedicine for chronic disease management, hospital at home models, wearables, in order to extend the healthcare support to the other people outside the hospital. You also have proposed rural and ambulatory care as a key topic. Why is this the right moment for health systems to be paying much more attention to the periphery?
Yeah, so I think on the myself now holding accountable to not get excited about the technology, but look at the journey of where the community is going first. So it is an exercise that we all have to do. But if I look at where communities are going, and if we look at all of those forces coming together, right, in terms of our patient populations are aging, things that we have to do for criticality of mass, things like that, and then all of the advancements coming to market, we have for the first time the technology that is now able to close the gap, as I said earlier, on what is actually distance and what is actually time, right? So the community model of rural care is going to change significantly. And as a health system, if you're able to adapt that, if you're able to stop seeing it as, again, something on a balance sheet that is creating so much tension for us to say, we can't get to these patients, or these patients are actually not showing up because they missed their, because, they're traveling in, they're canceling last minute. We have slots that are not being met. So you have that tension that's naturally created because of rural care and how we're trying to serve those as an example. Or you have patients that are actually, by the time they show up, they're so much, they're not as healthy as what they could be because they didn't have access to monitoring and devices and wearables and things like that. But that's where the shift of paradigm will come now, where you need that event of saying technology is finally available. Technology can now be there to be able to shorten the gap of, if you can't get to the hospital within 3 hours for your appointment on a weekly basis, that's fine. Do you just need to come in once a quarter, as an example? So I believe that in two folds, right? So we look at health system viability, we look at cash flow management, being there for the community long term, looking at your geo spread, your footprint, and saying, let's start using this as an advantage. So how do we take technology that's now available in a very smart way and look to be able to harness that for at-home programs, remote monitoring, things like that, and then make it easier, right? So it goes both ways.
No, I fully agree with you. I mean, the technology, we have 5G, we have more accessible technology solutions, and so many other things. But there is another point here. The rural healthcare faces a specific paradox. The populations most depend on ambulatory or remote services often have the worst connectivity and the digital literacy as well. How do you design technology solutions that genuinely serve rural communities rather than just making the urban health systems more efficient?
Yeah. I think as every vendor needs help and support from our health systems actually to be able to better understand that. And as you're looking to reevaluate your, we're calling that geo footprint, or what you need to do for rural care, it's important that we're designing to the lowest common technology threat, right? Not necessarily the highest. So oftentimes when we design for a technology product and we go for release, we'll say, well, where can we serve 80% of the most? And I think that question now needs to change significantly. It needs to say, it's not where can we serve 80% the most, but how do we make sure that the adoption is driven on that lowest technology band, as an example, right? Where, and to your point, from a community rural perspective, sometimes you don't have the digital literacy or the advancement or even the want to adopt. So it's very much behooved then on vendors and technology creators to sit with health systems and understand, now that you've done your future casting and you can see how your community models are shaping and shifting, what becomes the minimum requirement. And I think that if we involve health systems more in those discussions, in those pre-designed technology discussions, to say, can you give us your minimum so that we can design to that as a reverse kind of goal product out, we would have a much better outcome in what is available today. We would already be further along if we did that more proactively.
Brilliant. I think this is the setup, how you put the care at the center of all these development. And I really appreciate this approach. But I have to ask you another thing. I was in LA a couple months ago. And then what I have noticed, the acute settings are always busy, busy. I mean, they have bed availability problem and so many other things. And what I have noticed, and it's not just US, even in the rest of the world, it's happening. The ambulatory surgery centers are growing rapidly, and the health systems are trying to shift the cases to the ambulatory surgery centers in order to create, I mean, better capacity for the acute setting. From an equipment and infrastructure perspective, what are the unique challenges of getting ambulatory facilities right, do you think?
Ambulatory care is one of those things where it's highly critical, highly needed when we're looking at mass populations or remote segments where we have to have the interoperability. And to be able to get that mix right is critical. So you only get one chance in every kind of capital cycle to design a facility like this. And ambulatory care has become so much more important now because we no longer have the opportunity to wait for, let's say, these big hospitals to be built out. Or even if we build out great big hospitals, they're no longer really accessible. I love your example of saying you're sitting in LA, or you could sit in New York, or you could sit in London, in any one of these massive centers to say, and people, if you look at kilometers, oh, I'm 7 kilometers away from a hospital, or what is that in miles, right? But it would take them hours sometimes to get there. So the accessibility and the nature of having these big hospital centers are no longer always what is palatable in terms of what we need in communities. So ambulatory care centers, from a design perspective, when we're looking at equipment and acuity, I say that those centers need to be very, very tied into the community goal of what the hospital needs as a shepherd. So I go back to hospitals and being the shepherd of the communities and working with ambulatory centers to say, look, we need you very much. Like if we're looking at our population, we need you to be able to do cataract, knees, and hips all day long so that we can actually relieve the pressure off of the hospital for these more advanced cases or complexity in what we need you to do. So where we see ambulatory becoming very successful is when they're actually woven into the hospital system or into their community network, and they're working together in terms of one fabric. They're not just going out and saying, we're going to run all these cases from an adaptability standpoint. So
So it is
that is,
kind of an
yeah.
extension of the hospital, and then they can have a good integration. So then they will understand each other better, and that they can provide the best services.
Absolutely, and it's not a matter of just kilometers or geographic, right? So in terms of planning that out systematically, now when that changes and when that rolls over, we talked a little bit about what it means to be connected or have the interoperability, right? Now, if hospitals and ambulatory centers and all working as one network are actually doing this in a way that is symbiotic in that walk, and they're working collaboratively, you should see a lot more stress come down off of the community. You should see people getting cases that they need, the care that they need, whether it be home health, at the ambulatory center, in the major center. So I believe that ambulatory centers, from a capacity perspective, from a planning perspective, it's very complicated. You've got one shot to do it right. But the power of them is that you can stand them up very, very quickly in terms of having a little bit of that reverse effect and not having patients wait for a year or more to have a new wing built or something like that in a hospital.
I totally agree. And it's not just ambulatory care centers. I think we can also consider the rehab centers because the length
Mhm.
of stay is a problem in all these acute settings. And what I have noticed in LA, the hospital that we work together, Cedar Sinai, got the collaboration with the rehabilitation center over
Right.
there, the Rehab Institute. So then they were able to collaborate together because the important thing here, we don't want to consider those ambulatory care or the rehab places as a standalone places. They may not have the depth of quality investment, digital investment, and the others. They can get the support from the main hospital, so then the patients could get the best support out of it. And I appreciate, I mean, your leadership on that and trying to bring these units together.
Yeah. And well, I mean, long-term care. So one of the things that we were just perplexed with in one of the last builds that we did is just how many long-term care facilities are actually not connected into the main network. So when we're talking about interoperability, but now we have to make it affordable. Now we're getting down into these are conversations that I think are so necessary. And again, from the support of health systems, right? Of hospitals to say we want to have visibility to be able to what's going on and help with the at-home care or the long-term care facilities. But unfortunately, this is where the costing comes from. So those are all great things that I encourage health leaders to keep bringing into your technology design partner so that we can design the right things for what you need.
Definitely, starting from the integration of the EMRs and the others. So, as just
Absolutely.
you said, I mean, we have so many healthcare leaders watching and listening these episodes. So, I just want to shift a bit to the healthcare leadership part. And as a person coming from operation and commercial at the same time, I'm sure you can advise us in a great way. One thing what I argue that the single biggest predictor of a failed digital transformation isn't just the technology, it's about the absence of the cultural safety. You know that. So staff need to feel safe to say that, look, this is not working without consequence. How do the most effective health system leaders you have worked with create that kind of environment, especially in organizations where the hierarchy is deeply embedded?
Yeah. I see health systems, the transformation of the technology is one thing, but I love how you're bringing it back to the human centric and the culture of it. Because one of the things that we've just through research and then just our own, what's worked, what hasn't worked, and we can see how long we're going to be on that transformation journey with a system based on the culture that they're adopting. And if health leaders as a whole, and I talked a little bit about if you're going to take on transformation, you're going to own that as part of your culture, as part of your core. If you treat transformation as a project to give to a COO or to give to a department and say, you're leading transformation, go for it, the adoption will be very topographic. It will be very, very service level. It will be emails that goes out, communications go out. We've done this changeover, thumbs up, everybody. Unfortunately, you will not have a successful transformation. You'll have a very expensive shelfware we talked about. Where we see leaders really embrace the transformation and they themselves embody it, right? Where we have CNOs that will be vulnerable, that will go into the rounding meetings to say, this is very new, but I'm willing to learn it and I'm willing to actually adopt the new system and I'm going to do it with you. So when we're seeing leadership at every level, embracing the technology and they themselves being brave to call when something doesn't feel right or to say, you know what, we're still in adoption and it's okay, right? So your CNO is being vulnerable, your charge nurses are being vulnerable. They're saying we're using it. We know that it's going to continue to improve as it goes, but that's how technology learns. It has to learn our ecosystem. We have to realize that a technology that's coming to market or being integrated, right? Very, very plainly, you can have chief nurses say or section leaders say, look, the technologies came to us. It knows maybe 70% of smart, but we now know that as we give it information, it's going to learn from us. So let's treat it like that infant growing up with us. And I think that's probably the best thing that I can harmonize for leaders across health systems to say, how do I better angle my people towards wanting to do transformation? Transformation and digital transformation has become such a big buzzword, right? But I look at it now from the lens of saying you're actually bringing an infant into your organization. You need to feed that infant. You need to actually be able to teach it what it is that your culture is, how you work, some of the standards that you already have so that it can grow with you. And then your infant will actually be able to lead you and it will become this system that everybody loves to use. So by bringing that transfer of mind to leadership teams and to say every level of the organization needs to actually be able to be on the journey with that infant has been very powerful.
Totally agree. Totally agree. I think this is what the engagement we need from the people. And then we need to just design and continue to maintain and manage all these things together. So here, I had to ask you another, questions. Leadership in such digital transformations are very important. And then we need to have the leader actually leading this because I like the way what you have said, COO leading the digital transformation, CNO leading this part. It's not just about the IT project. We want to see the leaders on board. So for the healthcare leaders listening right now, leaders who are managing large organizations under significant financial and operational pressure, what is the one behavior change that will most improve their ability to lead a successful digital transformation, you think?
They need to lead it from the center is what I usually say. So digital transformations or adoptions so often are actually led from the peripheral, right? So you've got teams saying, I've got my IT team working on this. I've got my CIOs working on this. We've got our various departments kind of working around and everybody just kind of continues business as normal in the middle, which actually is where you need the transformation to be in the middle and then filter out, right? So I always tell health systems, if you want your transformation to be strong, set up your keys. You need your leadership team aligned. Everybody needs to now have this transformation at the middle. It's at the core. It is going to become part of what we do every single day. And it needs to just become the embodiment of how we work. We need to be brave. We need to be the early adopters. We need to have our team see that we're doing this and that it is a matter of saying, as part of my responsibilities for my part of the organization, this is how we're treating it from the core. It's not a peripheral. It's not being done on the bookends. It's being done right in the center. And this is how we're going forward with it.
Amazing. I mean, thanks for this vision. And I think we need to keep explaining, teaching, and guiding the healthcare leaders in this format. I really enjoyed this conversation, but we're already getting close to the time. I will close with a question, Nancy. I ask in a style of connected care, a question that I think is no longer science fiction. Will there be hospitals in the future? And if so, what will they look like?
I believe that there will be hospitals in the future. I believe that we will always need to have physicians that are able to care and understand the human better than any technology ever will. I don't believe that that will ever go away. But I do believe that hospitals will look significantly different. I think that they will be a center of excellence and a center of innovation, and they will be the hub of where great things are actually developed and then filtered and cascaded through to communities, where they will feed home health, where they will feed at home models, where they will feed a community centric hub and spoke model. So, hospitals of the future, absolutely. They will become more so a guiding light of a center of excellence to be able to then harness their community and not so much where endemics happen.
Excellent. Now, I love this vision, and I can definitely agree with you. I can't agree more. We're going to go outside the hospital's walls. And then, even though so many health systems in US still invest in the admission beds, I think this will be different in future. And then we will see more and more rural services. And then we need to bring more technology in order to manage these patients. So the final question, Nancy, what is the one thing you believe will be true about the healthcare in 2035 that most leaders today are not yet ready for?
I believe what will be true about healthcare in 2035 is that every patient will have a digital carbon copy of themselves. This will actually harness your health physicians to be able to understand the patient in a data backed way. And will also actually be able to harness your digital ecosystem through that full chain. So, in remote areas, community areas where we're talking about, it will no longer matter where you sit from a local perspective or from a global perspective. I believe that that digital carbon copy or digital twin of the human will actually exist based on all the data markers. And then we'll be able to actually plan and design healthcare proactively based on that human, regardless of where they are around the world.
Thank you so much, Nancy. This has been a remarkable conversation, Nancy. And thank you so much for your time. And thanks for sharing all these great vision for us.
Thank you so much. It's been such a pleasure.
Thank you. What I love most about our conversation is that it proves what I have been arguing in connected care for years. The technology is no longer the bottleneck. The imagination, the leadership, and the will to redesign care around the people. That is where the work is. And you're doing that work every day. Thank you so much for this. Thanks for your leadership. For
Thank
our listeners, thank you so much. For our listeners, I hope you have taken from today's conversation not just a set of insights, but a permission to think bigger about what organization is capable of, what your organization can do even more. The link to Nasty's profile and today's episode notes will be in the show description. And if today's conversation sparked something for you, I would love to hear it. Reach out, connect with us at chiefhealthcareofficer.com. And if you have not picked yet the book of Connected Care, my book, it's available now. Until next time, keep leading with the purpose. Thank you so much again. Thanks for listening.